Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I am Abhiraz. Welcome to our Clock to 50 Matchmaker sessions. Here in this video, we will be talking about restrictive lung diseases. So restrictive lung diseases, the key point is you can't get the air in, so there is the less air out. So the reduced FVC because of less air in and less air out, reduced FEV1 because of less air in and less air out. So normally the FEV1 by FVC ratio is normal. That is if it is more than 80%, which is the hallmark of respiratory lung diseases. So it is due to the either poor breathing mechanics or interstitial lung diseases. So poor breathing mechanics is not a primary pulmonary issue. It is under the ventilation. It is the under ventilation of lungs. So alveoli is working. So the AA gradient is normal. Maybe due to some neuromuscular causes like amyotrophic lateral sclerosis and polio, myasthenia gravis, or some structural causes like scoliosis and morbid obesity, which means that there is some defect other than the lung, the proper lung itself. Okay, the alveoli are working. So it is due to the poor breathing mechanics. The AA gradient is normal. So interstitial lung disease maybe the other cause of restrictive lung disease. So here we can see the bilateral diffuse pattern, the small irregular opacities, the reticulonodular opacities, okay, in both of the images, and here you can see the honeycombing appearance of the lung, which occurs in case of interstitial lung diseases. So the diffusion capacity in lung of carbon monoxide or DLCO, which separates the cases of restrictive lung diseases. So if there is restriction with normal DLCO, which means it is of extra pulmonary cause, for example, obesity. But if there is restriction with low DLCO, which means that there is interstitial lung disease, which is causing the restrictive pattern of the PFT. So the DLCO, which is the diffusion capacity of carbon monoxide, measures the ability of the lungs to transfer gas to RBCs. The patient inhales a small amount, not dangerous amount of carbon monoxide. So carbon monoxide uptake is diffuse and limited. So amount taken up is nearly equal to the diffusion function of the lungs. So then the machine measures the carbon monoxide exhaled. So normally we should exhale 75 to 140%. Okay, but in case of severe disease, we exhale less than 70%. So low DLCO is present in case of interstitial lung disease, emphysema, or in case of pulmonary hypertension, pulmonary embolism, prior lung dissection, and also in case of anemia. But when we correct anemia, so then the DLCO comes back to normal. In case of interstitial lung disease, like in case of idiopathic pulmonary fibrosis, scleroderma, rheumatoid arthritis, Goodpasture syndrome, vaginous granulomatosis with polyangiitis, sarcoidosis, and pneumoconiosis, in case of some drugs like amiodarone, methotrexate, this methotrexate can cause lung fibrosis. Also in case of hypersensitivity pneumonitis. So these all may be the cause of interstitial lung diseases. So idiopathic pulmonary fibrosis is the one concept that is very commonly asked in the examination. The most common type is idiopathic interstitial pneumonia, which occurs with slow onset dyspnea and typically affects adults over the age of 40 years. So here we have a 65-year-old man who presents to his primary care physician with complaints of progressive dyspnea and exhaustion and a dry, non-productive cough that has been present for the past 6 months. He denies any significant medical history and reports no history of smoking. Physical examination reveals bibasilar inspiratory crackles on auscultation. High-resolution computed tomography of the chest shows bilateral reticular opacities with honeycombing predominantly in the lower lobes. Pulmonary function tests demonstrate restrictive lung disease with decreased FVC and decreased DLCO. Now, which of the following is the most likely diagnosis? COPD, bronchiectasis, idiopathic pulmonary fibrosis, sarcoidosis, or lung cancer. So the clinical presentation, imaging findings, and pulmonary function test, they all highly suggest the idiopathic pulmonary fibrosis. So this patient presents with progressive dyspnea and exhaustion and a dry, non-productive cough. These are the common symptoms of IPF and are typically insidious in onset, worsening over time. Bibasilar inspiratory crackles on auscultation are characteristic finding of pulmonary fibrosis, including IPF. High-resolution CT scan of the chest showing bilateral reticular opacities with honeycombing predominantly in the lower lobes is classic for IPF. Honeycombing represents the interstitial fibrotic changes in the lungs and is highly specific for IPF. Pulmonary function test. restrictive lung disease with decreased forced vital capacity and decreased diffusion capacity for carbon monoxide are consistent with IPF. So let's talk about some pneumoconiosis. So the coal miner's lung, whenever there is inhalation of coal dust particles, and in case of in the chest X-ray or chest CT, we can see small rounded nodular opacities, and the preference is for the upper lobes. So remember, is like that. The coal comes from underground and it affects the upper part. So comes from underground, affects the roof. Comes from underground, affects the roof. Silicosis is when there is inhalation of silica dust, most widespread pneumoconiosis in the US. So in case of metal production facilities, in case of sandblasting industries, in case of mines, there is the patients who work in these workplaces are most exposed to silicosis. The macrophages react to silica and there is inflammation, fibroblast, and then there is the collagen deposition. But there is high prevalence of TB in case of silicosis patient due to the impaired macrophage killing, and there is also high prevalence of bronchogenic carcinoma. Asbestosis is when there is inhalation of asbestos fiber in case of shipbuilding, roofing, and plumbing, and this classically affects the lower rows. Remember it like that. So asbestosis comes from the roof and involves the floor. Comes from the roof, affects the floor of the lung. Okay, coal dust comes from the floor, affects the roof of the lung. There are three clinical problems that are occurring in in patients with asbestosis: interstitial lung disease, pleural plaques, and lung cancer. And in chest X-ray, we can see the calcified pleural plaques, which are pathognomic of this disease. And in case of histopathology, we can see asbestos bodies or ferruginous bodies. Okay. Now, this picture is very, very important, and you can just diagnose asbestosis based on this picture and save time in the examination. The asbestos fiber are surrounded by a coating of iron and protein, and these are called asbestos bodies. Now, there is incidence of bronchogenic carcinoma and mesothelioma in case of patient. Bronchogenic carcinoma is most commonly seen with asbestosis, and mesothelioma is most specific for asbestosis. So don't confuse in exam, okay? Don't confuse yourself in exam about which one is associated highly with asbestosis, okay? So associated highly is bronchogenic carcinoma, okay? And which one is associated specifically with asbestosis, then that is mesothelioma, because asbestosis is the only known risk factor for mesothelioma. It occurs decades after exposure. There is pleural thickening and pleural effusion. There is slow onset of symptoms, that is dyspnea, cough, and chest pain, and it typically have a poor prognosis. So a 60-year-old man presents to his primary care physician with complaints of progressive dyspnea, chest pain, and unintentional weight loss over the past few months. He has a history of occupational asbestos exposure as a construction worker. Physical examination reveals dullness to percussion and decreased breath sounds over the right lower lung field. Chest X-ray shows pleural effusion with associated pleural thickening. Which of the following is the most likely diagnosis? So mesothelioma, as you all know. Now, this sarcoidosis is one of the very important concept or topic for the USMLE examination. So, sarcoidosis is characterized by immune-mediated widespread non-caseating granuloma. Here, we can see the granuloma, elevated serum ACE levels, and elevated CD4 CD8 ratio in bronchoalveolar levels fluid. It is most common in black females, often asymptomatic except for enlarged lymph nodes. So the enlarged lymph nodes may be generally the hilar lymph node. Okay, so the chest X-ray shows bilateral adenopathy. So this and this, there you can see the hilar lymph node involvement and coarse reticular opacities. The CT of the chest better demonstrates the extensive hilar involvement. Here and here we can see the hilar involvement. It is associated with Bell's palsy, parotid enlargement, granulomatous diseases, rheumatoid arthritis, increase in calcium, interstitial fibrosis, vitamin D activation. Okay, and the treatment is generally glucocorticoids if it is symptomatic. Thank you for watching. Keep studying hard.